Good morning, everyone. This is Leanne Griffin with FATA. We expect to get started on time in about 5 minutes. In the meantime, you may find it helpful to check out the chat panel. I'll be posting some technical information in the chat panel throughout today's event. I'll check back with everyone in 5 minutes. Dr. Gastfriend, this is Leanne. Can you hear me okay?
I hear you fine. How are you?
I'm just fine, thank you. And we do expect to get started on time in just a few minutes.
Okay, great.
Thank you. Good afternoon, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Contingency Management, an Underused Treatment Approach for Opioid Use Disorder. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions today, please send them to the presenter and me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will answer questions at our break and again at the end of the presentation. Our audio is being broadcast through the internet to your computer. You must have speakers attached to your computer and have the correct software and the volume on. If you do experience poor computer audio, there are a few options to try on screen right now, and these options are also posted in the chat panel. If you continue to experience a loss of audio or poor audio through the computer speakers, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio portion of the presentation and view it on screen to be eligible for a statement of credit. The recording and materials used in today's presentation will be available on the FADA website within 5 business days. Also, a PDF version of this PowerPoint presentation will be emailed to the participants within 5 days. As many of you know, FADA produces many webinars through the support of the Florida Department of Children and Families. To help participants track credits earned through webinar attendance, we have launched a new website that provides a personalized digital journal where participants can maintain statements of credit for every webinar and workshop taken through the Florida Alcohol and Drug Abuse Association. So at the conclusion of today's webinar, as usual, the web browser will direct everyone to an evaluation form on the FADA website. You will be prompted to register or log in to complete the evaluation. Once you do register and complete the evaluation, you'll be able to access a statement of credit right in your member profile. Keep in mind, of course, that any information you provide FADA as part of registering remains confidential. Also, as usual, completing the evaluation is necessary in order to receive CE credits or to access your statement of credit. And the evaluation does close on Thursday, March 15. Approximately 1 to 2 continuing education credits are available for participating in today's webinar. For persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, please be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide that number to us when you register with our site. Do note that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial credit. At this time, I'd like to introduce our presenter for today's webinar. David Gastfriend, MD, is Senior Research Scientist at the Treatment Research Institute. An addiction psychiatrist, he directed addiction research at Massachusetts General Hospital and was an investigator in the NIDA Cocaine Collaborative Study, the NIDA Combined Study, and the NIDA Clinical Trials Network. As the Vice President at Alkermes, Inc., Dr. Gastfriend conducted biological, clinical, health economics, and policy research on behalf of the company's efforts in the field of addiction treatment. For 25 years, Dr. Gastfriend served on the faculty of Harvard Medical School, notably as the Director of the Addiction Research Program at Massachusetts General Hospital and founder of the MGH McLean Hospital Fellowship in Addiction Psychiatry. Dr. Gastfriend is considered the world's leading expert on two important treatment tools from both the biological and psychosocial realms, the opioid blocker Vivitrol and the American Society of Addiction Medicine Criteria software. And we're very pleased to have Dr. David Gastfriend join us today. And Dr. Gastfriend, if you're ready, I'm going to turn control of the presentation over to you.
Great, thank you so much. And thank you, everyone, for joining this call. There are over 115 of you on the line right now, and I'm gratified to see that degree of interest in what is really a very important treatment model that is just, unfortunately, badly underutilized. So we will, and I don't see my slides yet. I just see the intermission slide. But we'll
Dr. Gastfriend, hold on. Let me take control back, and
okay.
I'll make sure your slide's up. And then when you see it, I'll turn control back to you.
I see it now.
Okay.
All right. Well, that looks familiar. I really think that this is the greatest unused treatment in opioid use disorder. And I hope by the conclusion of this workshop, you'll see why. I want to disclose to you that I have a number of financial conflicts that you should know about. One is, the most important one is the second line here. I am the co-founder of a for-profit startup health technology company called Dynamic Care Health Incorporated. And that is a company that does work in contingency management, and therefore I do have not just expertise in this area, but also a financial conflict of interest. So you should be aware of that. We're going to talk about this really potent evidence-based practice, EBP, in substance use disorder, and it's called contingency management. And we abbreviate contingency management as CM. And the vast majority of providers in our country do not use CM or don't use very much of it at all. So what I want to do in this webinar is review with you the theory of CM and its origins and what it comes from, which is operant conditioning, the behavioral psychology paradigm of operant conditioning. I want to discuss its evidence base in terms of random controlled trials, our current understandings of what are the best practices in delivering CM, including what's not really fully known about contingency management. And there are a lot of obstacles about it, logistic, financial, ethical, training obstacles that have impeded its adoption. So I want to cover those with you and how new technologies might be used to solve these challenges to facilitate gaining adoption of contingency management into routine clinical care. So at the end of the workshop, I hope that you, the participants, will be able to comprehend the theoretical and research basis for adding CM to counseling and adding it to medication-assisted treatment when you care for patients with opioid use disorder. And we abbreviate medication-assisted treatment as MAT, and opioid use disorder we abbreviate as OUD. So I want you to understand the best practices for using CM and to assess the challenges and potential solutions in order to be practically minded about how could you implement it into your routine clinical care in your program. Now, why is this so important? Well, because we have an epidemic. Over the decade and a half, from 1999 to 2014, prescription opioid sales and deaths increased fourfold. They quadrupled. Now, there wasn't really any change in the amount of pain people had in America, yet we increased the sales of opioids and we increased the rate of deaths by fourfold. So that's a pretty striking finding that there's something wrong with how we have begun using opioids. And the quantity of deaths is enormous. 600,000 deaths have occurred through overdose in the period 2000 to 2016. And that's more deaths than the entire Vietnam War. So this is an enormous degree of loss in our country. In 1 year alone, in 2016, we had 42,000 deaths. And 40% were due to prescription opioids, not heroin, not fentanyl, prescription opioids. So we see it in all genders, men, women, all races, all adult age groups. And the rise is going to head above 60,000 in terms of annual deaths. And what's causing this continuing rise? Because doctors are starting to withhold their prescribing of excessive opioids. Well, it's being driven by a five-fold increase in the rate of fentanyl use. And that's in a very short period of time, from just 2013 to 2016. So that's a very frightening situation. And it's not just a national epidemic, it's right in Florida. There is a significant increase in the rate of deaths just from 1 year to the next in Florida. From 2015 to 2016, a significant increase in deaths, and a more than doubling in Florida in the rate of fentanyl deaths, 115%. Right, 100% would be a doubling, and this is more than a doubling in the rate of fentanyl deaths in Florida just from 2015 to 2016. And we knew about the fentanyl risk in 2015, so it's not like we had no idea it was there. But when we think about the rate of deaths, the rate of overdoses, the rate of addiction from opioids, we have to come to terms with the finding that the number of Americans who need substance abuse treatment is vastly larger than the number who are getting substance use disorder treatment. 20 million Americans, that's 8% of our adult population, needs substance use treatment, and only 10% are getting any specialized care. So these figures are pretty daunting, and that's why we need to be working on our models and improving our delivery of care. So the death rates are surging over recent years, and you can see it's not declining, it's not leveling off, it's not even stabilizing. The rate of increase is getting more acute. This incline is a sharper angle than in the preceding years. So that's really a sign of an epidemic. And when you break it down, we're not seeing a rise in deaths from methadone because that's an effective treatment. We're seeing a rise in deaths from opioids that are prescribed, but it's not rising as fast. Even heroin is not rising as fast as fentanyl and carfentanil and other higher potency synthetic opiates. And we use the term opioids for all of these different compounds, the natural and the synthetic or man-made versions. So opiates is the natural, plant-based opioids, and opioid is for the entire group. So these deaths are surging. We're not getting ahead of the curve yet, and that means people right in our communities, right in Florida, are continuing to die at remarkably terrible rates. It's not just an issue of life or death. It's also an issue of economics. This is a figure that I never thought in my career, which is now over 35 years long, I never thought I'd see a figure of $500 billion in a single year costing our nation. But in fact, this is what the President's Council of Economic Advisors tells us. $504 billion lost in healthcare, accidents, deaths, lost productivity, criminal justice, all the different aspects in which opioid use disorder damages our society. So the opioid epidemic is also an economic crisis, not just a health crisis. Opioids are now the principal cause of death of Americans under age 50. Think about that. Opioids. These are pain relievers. These are drugs that are supposed to help us be more functional and heal, and in fact, they're killing us. And 27% of the total societal costs of prescription opioid abuse are from lost earnings due to premature death. We actually have a declining longevity among U.S. adult white males because of the opioid epidemic. So the first time in history we've had a decline in longevity among this major portion of our population. So there's also reduced employment and compensation to people for their disabilities. Employers are actually telling us that they have labor shortages. This is in a period of time when people couldn't get enough jobs. And in fact, there are companies that are going with unfilled jobs because so many workers applying for jobs in their communities are failing drug tests because of opioids. So this is now of concern at the level of the Federal Reserve Bank. And the counties with the highest poverty rates are experiencing the largest increases in opioid-related overdoses. So yes, it's affecting all strata of society, but the inequities between the poorest and the richest in America is being aggravated further by the opioid epidemic. In fact, heroin abuse, as opposed to prescription opioid abuse, is most prevalent only in those with household incomes under $20,000, so only among the very poor. So we're seeing higher death rates in those without college and those without employment. In terms of drug and alcohol death rates rising 10 times faster in middle-aged white males without college than if they have a college degree. And these researchers, Case and Deaton won the Nobel Prize in Economics 2 years ago. He's a Princeton economist, for discovering that our adult white male longevity is now declining in this country, no longer increasing. So the disparities affect the unemployed much worse than the employed, and so we have both a public health and an economic crisis. And we're not just needing to address this because it's a health problem or an economic problem, but because it's a justice problem. It's a cause of inequality in the U.S. So why do I focus so much on economics? And the reason is, okay, if we have a drug problem that is an economic crisis, maybe we could use economics to be part of the solution. That's a big concept because when we do counseling with patients, we spend very little time thinking about economics. And yet, there is an entire field of study called behavioral economics that gives us a remarkable tool for addressing this health problem, addiction, with the use of economics. Let me explain how economics plays into this disease. So this disease is a brain disease. It really starts not in wrong thinking. Nobody starts thinking in the outer portion of their brain, their cortex, this big part where man does his thinking. People don't say, you know, I'd like to become a heroin addict. maybe I could go to my doctor and get pills, and that could get me addicted to pills, and then I could become heroin active. That's obviously absurd. What happens is people start using pills that their doctors prescribed for a legitimate purpose, and after a while they realize that they can't stop using the pills. This is not happening at the outer region of the brain where we do our thinking or our decision-making or our reasoning. This is happening at a much deeper region of the brain called the limbic region. And the role of the limbic region is to manage basic drives and the experience of reward and euphoria. And this limbic region is not available to conscious thought. It's a chemical processing unit. And the chemistry is responding to either our own internal signals of comfort or pleasure or drive, like dopamine or endorphins, or it'll respond to artificial chemicals that come into the brain, like opiates, heroin, fentanyl. So this chemical response is more like a reflex, and it's not like a thought process. As a result, we can stabilize addiction if we can stabilize the limbic region, and the interventions are the medications. And I've provided a number of webinars already this year and a couple more to come on the medication interventions which work at the level of the limbic region or the drive region. And to deal with the cortex, we have to use counseling, psychosocial therapies, 12-step programs, monitoring patients. But those are effective if we have a stable chemistry. If the chemistry is unstable, it doesn't matter how much counseling we do, we're not going to benefit the disease and overcome it. Because fighting this disease with only actions at the cortex, counseling, is fighting with one hand tied behind our back. We need to address both regions. And it's a little bit more complicated than just two regions because in these different regions we have different functions. In the non-addicted brain, we have drives. Those drives are stimulated by rewards, and the more exciting a reward is, the more drive gets stimulated. We remember how reward affected us and how exciting the reward was by storing that information in memory. But fortunately, we also have a region of the brain that manages impulses. So for instance, the caveman who's hungry, and he's got his cave woman and his cave baby starting to be in need of food. And he smells the rabbit outside of the cave, and he thinks, oh, good, rabbit, I'll go hunt. But then the drive system is counterbalanced by another thought process or electrical process in the brain. Because he also hears the rustling of the saber-toothed tiger. And he thinks, oh, saber-toothed tiger, maybe I shouldn't rush out and get the rabbit. And he exhibits impulse control at this point. So if impulse control is strong, it can balance even a pretty salient reward, an important reward, and hold off on drive so that we can get a no-go response, an inhibited response. The behavior doesn't go forward until it's safe again. And that calculation and balance is critical to survival of the species. It's there. These structures are present to some degree or another in animals all the way down to the lizard, back at the time of evolution hundreds of millions of years ago, even before the dinosaurs. But what happens in the addicted brain? Well, in the addicted brain, the rewards of the opioids become excessive. The memory for that is very, very firmly entrenched. Impulse control is diminished because of the pain of withdrawal. As a result, the impulse control to say, you know, this opioid is hurting me. It's hurting my life. It's hurting my income. It's hurting my relationships. That impulse control is weakened over time, and the reward saliency is enlarged. As a result, we have a go response instead of a no-go response. And that leads to addictive behavior and addictive compulsive behavior and the destruction of a life. So where does contingency management fit in? Well, the important thing to understand is that contingency management is active not at the region of the outer thinking brain, like our other counseling approaches and 12-step approaches are. Contingency management is literally working at the level of the chemical brain. It is a fundamental reward system, an incentive that heightens motivation and switches from instant gratification for drugs to instant gratification for healthy behaviors. So it is acting at this more subliminal or unconscious level, like medications. And it's actually used in a lot of different fields. It's used a lot in education and in managing children with cognitive impairments. It's used in Alzheimer's behavioral management. But it's most widely used and researched in substance abuse. Our field actually has the best science in this area. And there's another activity that behaviorists do called clinical behavior analysis. It's often implemented as part of that. It's a form of operant conditioning. And operant conditioning, which came about shortly after work by Pavlov and those scientists back at the turn of the 20th century, is actually a very powerful system that models how the brain reacts. And it uses a combination of stimulus control, and that's what we mean by the rewards. They are a stimuli. And it uses a combination of positive and negative reinforcement to change behavior. Now, what's positive reinforcement? Positive reinforcement is something good happened to me, I like it, I want to do it again. So the like it is the positive, and the reinforcement is I want to do it again. Negative reinforcement is something bad happened to me, I don't like that, so I don't want to do it again. It's like punishment. There's some more technical aspects to this, but I think this is an easier way to understand it. So if we could reward patients' behaviors and infrequently punish unhealthy behaviors so that they adhere to program rules or to a treatment plan, we would be using stimulus control and positive and negative reinforcement. So we use this model, which comes from applied behavior analysis, and it produces one of the most impressive effect sizes for improving health and behavior out of all the mental health and educational interventions we have. All the different treatments we have, counseling, relapse prevention, cognitive behavioral therapy, this produces more substantial behavior change than pretty much anything else we have, except medication. It is similar to the effect of medication in terms of changing behavior. That's how powerful it is. And yet, it's not a medication, which means you don't have side effects like with medication. So there are many approaches to using contingency management because rewards can be financial, you can use vouchers, gift certificates, opportunities to win prizes, or even privileges. And we'll talk about methadone take-home privileges, which is one version of contingency management. There are schools that operate on a token economy, and it works with children with special needs, people with stuttering problems, delinquent youngsters. And the goal is you use the CM to initiate healthy behaviors and sustain them. And the goal is to transition from the rewards for the CM incentives to eventually just letting people feel motivated for and seek rewards for natural reinforcers, like getting a job, getting a paycheck, having a relationship, building a home, raising a family. Those are the natural reinforcers that we all respond to if we're healthy, and it's what CM is designed to help people transition to. Now, voucher-based CM has been used in a number of research projects, and it gives vouchers for retail items. It could be for a hamburger at McDonald's. It could be for paying your electrical bill. And it gives vouchers for things like staying abstinent or compliance with other behavior change targets, like going to meetings or going to counseling. And voucher-based CM was introduced in the 1990s for cocaine dependence, and we don't have a medication for cocaine dependence. So this turns out to be the single most effective method we have for getting new patients coming off of cocaine to establish and maintain their abstinence. And it's in a bunch of controlled trials. This is really well established. Privileges can include medication take-homes, and that's pretty frequent in methadone programs. So the patient's permitted to earn take-home doses of methadone in exchange for increasing healthy behaviors like showing up on time regularly, going to counseling, enrolling in a vocational training program and attending it. Or it could be for decreasing behaviors like showing up late to get the methadone, or for ceasing behaviors altogether, like for maintaining abstinence and no drug use. And take-home doses or take-home bottles are very desirable rewards for people going to a methadone clinic every single day, because they're going Friday, Saturday, Sunday, holidays, snowstorms, they have to get to the clinic. Otherwise, they don't get their methadone. So take-homes can be a very desirable incentive reward. And they might start by getting one take-home dose per week so they can skip a day and sleep late. And this might be after they submit a negative urine drug screen for 3 months straight. And if the patient lapses, if they turn in a drug screen that's positive, that has opioids in it, they could lose their take-home privilege either briefly, if it's just a lapse, if it's a brief period of relapse, or if it's a full relapse and the patient is fully dependent, then it could be a long-term lapse or long-term relapse, and then they could lose their take-homes for the next 3 months. Let's talk a little bit further about the theory. I've started that, and I want to say some more about it. This is a complex disease when we talk about addiction, and a large part of that imbalance between excessively salient reward and inadequate impulse control is memorized. So reinforced learning, as they repeat the cycle over and over again, it becomes a learned pattern. That learned pattern is very powerful. People have trouble understanding, well, why would somebody who finally gets into recovery relapse so easily 10 years later? And I explain it this way. Remember when you first learned to ride a bicycle, and you got off the training wheels, and somebody held you, and then you pushed the pedals, and you learned how to hold yourself up with the centrifugal force of pushing those pedals hard enough to fight gravity. And then you ride your bike your whole childhood, and then you stop riding it as you become an adult, and you don't ride your bike for 10 years, 20 years. And then you have an occasion to get on a bike, and you remember. Doesn't matter how rusty you are. You could be wobbly, but you remember how to hold those pedals and push them hard enough with enough pressure to resist gravity and hold yourself up. That's the kind of reinforced learning that leads one to always remember the excessive appeal of a high and makes it vulnerable for them to relapse if they get too much exposure or too much stress and don't know how to manage those things. So this learning is mediated by the brain. It's mediated in that limbic region that I showed you before, in the dorsal striatum, and it becomes hardwired through procedural learning. Procedural just means the process of doing something over and over again. And the problem, as I said, with the example of the bicycle is when you have procedural learning, you're not going to unlearn those habits. Your brain neurons and their connections, the dendritic connections, they have actually been pretty permanently wired. And the only thing we can do is overcome those habits by learning new, competing habits. So we actually have to do repetitive behavioral activities to rewire new, healthier behaviors that become more salient or more appealing or more current. And we can do that. That's what CM actually does. This is why just talking about it isn't going to overcome the procedural learning that has become cemented in our brains with addiction. So we could be a great counselor. We could be charismatic. We could be a wonderful human example of recovery. That's an observation for the patient. That's a thought. It's not a wired set of neurons that would overcome the old established addicted circuitry of neurons. So we need to work with the limbic system below the cortex because it's wired to the prefrontal cortex and it drives the prefrontal cortex, that outer big thinking brain. So what does CM do? Well, it uses incentivized reinforcement learning, literally giving people rewards for the behaviors we want them to do and restarting the brain's reward system to entrain new behaviors that drive the procedural learning process and the process of recovery. And one of the beauties of this is that nothing about doing this disrupts or competes with the learning process of counseling and 12-step fellowship and the other excellent approaches we also need. There's no competition between them. One just supports the other. If we stabilize the limbic drive system and its messages to the outer cortex brain, it allows the cortex to learn, to think, to decide in ways that are more stable, more functional, and more consistent with the recovery lifestyle. So I'm going to take a little pause and ask you to think about a couple questions. And you don't have to answer, but I want you to think about, first, are you even familiar with this concept? You might be unfamiliar with the concept at all, and so this may be the first time you've heard of it. You might have heard of it, but not really understood what it means. You might be aware of the principles of operant conditioning and reinforcing people for desirable behaviors. You might be further along than that. You might actually work in a program where you've seen contingency management used, but not used it yourself. If you've worked in a methadone program, you might be familiar with it. Or some of you perhaps have even used CM. So I just want you to take stock of where you started before this webinar, and we'll see, each of you will see how you feel about it when we complete it. I also want you to think about this question. Why can't we use it? Why don't we use it? Now, it may simply be, I don't know about it. I don't know how to use it. It may be that you do know something about it, but you believe it's unethical to pay addicts to do what they should do anyway. It may be that you worry about it violates regulations about paying patients money. It might be that you worry that the patients might buy drugs with the money. And if you have that concern, we need to address that so that this can be feasible. You might know enough about it to be thinking, well, wait, if we're going to be paying people money, we've got to have a place to store the money. We have to be able to dispense the money. We have to account for the money. Is the money the same every time? Is it small amounts of money? How do we handle all that extra work? And that would be something worth thinking about. Also, you're going to hear from me that best practices are to really detect abstinence in a foolproof way. If you're doing that with urine testing currently, it's kind of hard to do. Rigorous urine testing means you need to do observed stream. We can do temperature testing, we can do pH testing, but that can be challenging to be right on consistently. And observed stream testing is really difficult, and it's also pretty invasive for the patient. Also, true random testing is the most important way to know if people are really at risk. If you're only testing Monday, Wednesday, and Friday, or during work weeks, or during work hours, that's not true random testing because the patient knows when large blocks of time are that you're not going to be testing. So all of these can be reasons why we don't or we can't use contingency management. But contingency management is not new, and it's not something that people have been completely unable to do, or that it's not something that's been unethical. In fact, it's been around for 50 years. That is a half a century, folks. And the fact that we're still not using it is really distressing, at least to me. So this paper came out in 1968. We are now in 2018, to the best of my knowledge, and that means 50 years ago, we learned that there is a technique for controlling behavior in natural life settings, including in substance use disorder. And these researchers from Dartmouth gave us some very interesting instructions. They said, for instance, the response reinforcement relation should be set up so it is irrevocable, and the patient should be convinced that the manipulated behavioral consequences are inevitable. This just means that you have to do contingency management rigorously, and the patient has to know that the rewards or the punishments are really going to happen. A second condition of effectiveness is that the program should be sufficiently extensive to make probable the persistence of the improved behavior after the threat of reinforcer loss has terminated. And all that means is it should go on for a long enough time so that it really establishes the behavior. Another point is that if you should urge the subject to extend treatment if he doesn't feel confident. So the patient needs to make some choices too. If they think that they're really establishing a pattern, a habit, the procedural learning is working, then that's a time when treatment can conclude. If not, the patient should continue. So a variety of these findings were established early on, and there are now over 100 random controlled trials of contingency management. That's amazing. 100 random controlled trials. Well, that's as good as some of the best treatments we have in modern medicine in other diseases, like cancer and heart disease. You mean in addictions, we have that much proof for one of our treatments being really effective? Yes, that's exactly what I mean. And another sign of how extensive the research is that when there are many studies, other researchers will do independent meta-analyses. They won't do a new study. They'll actually analyze a bunch of previous studies and look at their data and compare them to one another in a rigorous way. And that's called a meta-analysis. There are now 7 different meta-analyses, and they show consistently things like contingency management appears to be efficacious for treating most drug use during treatment for opioid addiction. So it's not just for the opioids, it's for most drug use, including stimulants and benzos and other drugs that people use when they're addicted to opioids. It's among the most effective treatments for promoting abstinence. It's high efficacy with what we call moderate to large effect sizes. Now, they do weaken over time, so after a while we need to transition the patient to pursuing healthy, natural reinforcers. But it works across different substances of abuse, different populations, and in different settings. And it's a behavioral system that's recommended by the NIH, by the U.S. Surgeon General, by the American Society of Addiction Medicine, and even internationally by the United Kingdom's National Health Service. What's the reason that we think it's so effective? Well, let's look at relapse prevention. Here's relapse prevention in an analysis looking across many different studies. Here is contingency management. Well, it's almost twice as big an effect size as relapse prevention. It's more than twice as big an effect size as cognitive behavioral therapy. When you combine cognitive behavioral therapy and contingency management, you're getting to 3 to 4 times the effect size in terms of reducing drug use or establishing abstinence. So it's a very powerful treatment, even compared to things that we're using all the time. Think about how much you use relapse prevention, and you're not using the strongest treatment. Think about if you're using CBT, and you're not using the strongest treatment. The strongest treatment is combining these with contingency management, and so many of us aren't doing that. Now, contingency management has been tested and found to be particularly impressive when dealing with stimulants. And why? Well, that's because we have impressive treatments with opioids. We have buprenorphine and other treatments. We have treatments for alcohol dependence, but we don't have great treatments for stimulant use disorder. So the NIDA Clinical Trials Network, which is a very large system across the country, they did a study with 800 cocaine and methamphetamine users who were in methadone treatment. So they're in 14 methadone clinics around the United States, and they're on methadone for their opioid use disorder, but they're also using cocaine and or methamphetamine. So they were given prizes in drawings to get rewards for very simple things, gift certificates, over a 12-week period. The average cost for these prizes was $40 per month per patient. So it's not a lot of money, although you might say, well, we don't have that kind of money, and we'll talk about how to deal with that later. So the patients who reached 4 weeks of continuous abstinence from their cocaine or methamphetamine was several times higher, 24%, with contingency management compared to only 9% if they weren't getting contingency management. That's a huge increase in the rate of 4 weeks continuous abstinence. And the mean number of weeks among the people who were abstinent was 2.8 with contingency management versus 1.2. So it's a doubling of how long they were staying abstinent. So you see this upper line is substantially above the lower line. And the lower line is the usual care group. That's the frequency of drug tests that are negative for stimulants. And the upper line is the frequency for the people getting the incentives, the contingency management. In another study, this is counseling programs, they looked at retention. And what they found was when they used contingency management, 49% of patients were retained for the full 3 months of treatment, that's half, versus only about a third of the patients who weren't getting the reinforcements. And the duration of continuous abstinence in this group was, again, almost double, 4.4 weeks of continuous abstinence versus 2.6. So in stimulants, this is a very potent treatment, and we have no medications for stimulant treatment. There's no pill you can get the doctor to prescribe that will help people stop using stimulants. So the research, even in some of the most difficult to treat populations, is very compelling, and there's a lot of it. In fact, the rate of increase in published papers on contingency management over the past decade is really astounding. More and more evidence, and it's pretty consistent paper after paper. In the meta-analyses, they can quantitatively look at whether the bulk of these many papers supports the benefit of contingency management in patients being treated with MAT. So some of these papers are opioid use disorder patients who need to stop also using cocaine or other opioids, or smoking cessation, or polysubstance patients. So it's different types of populations. But when you put the average result, which is what these little red dots mean, if you put the average results and line them up paper after paper, what you find is all the red dots are on the right side of this zero effect line, meaning they all favor contingency management. And when you average them, the average is clearly to the right. And that's actually a pretty substantial and significant finding across all these papers. So it's effective, in fact, highly effective. And it can motivate the patient to reduce illicit drug use, increase adherence, and 4 trials looked at MAT, that is buprenorphine being prescribed, and they looked at adding counseling to MAT, buprenorphine, and they didn't find an extra benefit from adding the counseling to the buprenorphine. But there is evidence that when you add contingency management to pharmacotherapy, you do get a significant improvement in retention or in abstinence. So this is a big conceptual challenge for all of us. If we're doing therapy, we believe, we're convinced that counseling is important, including with buprenorphine, and buprenorphine alone is not effective. But 4 studies have now shown, at least short-term, that you don't get extra benefit, at least short-term, from buprenorphine, and yet contingency management does show that. Now, there's a lot of research on MAT in opioid use disorder. There's 43 papers. 22 were random controlled trials. All but 1 involved MAT with methadone or office-based buprenorphine. And what they find is during MAT, contingency management is efficacious for improving retention, the length of stay in treatment, and decreasing drug use. Which drug use? We see it for cocaine reductions, opioids and cocaine reductions, tobacco cessation, and polysubstance. Now, we don't see that CM is necessarily effective for reducing opioid use alone. Why? Well, that's because methadone or buprenorphine do that in and of themselves. But they don't decrease use of stimulants or tobacco or other substances like benzos. So when we add CM to methadone or to buprenorphine, we stabilize all these other problems as well. So I want to give you time for some questions. You can type your questions if you click in the question and answer box, the Q&A box, or the chat box. And I'll be able to see them and start answering. We have almost 150 of you on the line, so I'm sure there are some questions. And what I'll do is I'll offer you a 5-minute break now. Look at your cell phone, answer a phone call, go to the bathroom, get a coffee. Let's start back again promptly at 1 o'clock. And at 1 o'clock, I'll look at the questions you've typed in and answer any questions, and then we'll go on with the second half of the webinar.
Thank you, Dr. Gastfriend, and I believe that's going to be 2 p.m.
Oh, sorry, 2 p.m. Yeah.
That's right. Thank you very much, and we'll go ahead and be monitoring those questions. Welcome back to the second half of today's presentation. Dr. Gastfriend, there were some questions and comments that did come in. Would you like to address them, or shall I read them to you?
I can see them. Let me just make sure I can scroll.
And there was also an interesting one in the Q&A box as well as the chat box.
I can't see one in the chat box.
I've got several there that I'll be happy to read through to you if that's convenient.
Yeah, okay, go ahead.
Okay, the first one that's in the chat box simply asks, what do you think are the obstacles for why practitioners are not using contingency management?
Yes, we're going to have to talk about that in detail and also the solutions. I'm going to wait until we get to the slides for that, but you should have that framed in your mind now, so thanks for bringing that up.
Okay, and another one in that section is, what is the time frame that contingency is most effective, as well as the modality?
Yes, I don't know if I'm going to get to that, so let me answer right now. It's immediately upon entry into treatment. So if the patient is entering, just post-detox, entering any outpatient, intensive outpatient setting, if they're going into OBOT, if they're starting Vivitrol, then that's the time. When they're in rehab, it may not be as useful because their behaviors are more controlled by the setting, but as soon as they come out of rehab, that's the period of time to initiate CM.
Okay, and I saw there's one more in the chat panel, and then I think you have some others you'd like to address in the Q&A panel. Is that right?
Correct.
Okay, so the last one for the chat panel is, did any of the studies measure three things: contingency management, counseling, and MAT? Did all three together have an extra benefit?
Okay, so there isn't a study that I can recall that looked at all three together and all three separately. That would be a very complex study to do because you'd also need a control group of no treatment, and those studies generally don't get done. However, there certainly are studies looking at CM separately from and in combination with MAT, and CM separately from and in combination with counseling. And so the best effect in patients with opioid use disorder would probably be the combination of CM plus counseling plus MAT. And here's the reason. When patients are on MAT and you just want to reinforce them for staying abstinent, they'll stay abstinent. The reinforcers work really well for getting the behavior that you target. But if you target something beyond just abstinence, if you target utilizing CBT exercises and doing the coping skills learning, that's not something the medication achieves. That's really growth. And so if you target growth behaviors, if you target going to 12-step meetings, if you target, you can target any healthy behavior, going to vocational counseling, getting vocational testing, and starting a vocational rehab workshop. There are studies that have done that with vocational rehab workshop. And you will get people doing all of those healthy behaviors, and then the question is, can we transition the rewards to more and more natural reinforcers to the point where the patient gets a paycheck? And, the rest of us are responding to CM when it comes to a paycheck. What do I mean by that? Well, we'll work all week long to get a paycheck on Friday. And we'll work week after week after week to get to the next level, that is, a raise or a promotion. And we'll work really hard to avoid being punished by a setback, and that is losing our job or being docked our pay. And if we do lose a job or get docked our pay, we will work really, really hard to prevent that from happening again. We will really learn what we need to do to prevent that punishment? So those are really good questions, and you'll see more about this. I'm going to get into this in more detail in the next hour. So that covers the questions in the chat box. Is that right?
Yes, that's right.
Okay, so let me go to the Q&A box. Somebody asked, what kind of rewards would you recommend for drug court clients? That's a really good question, because in drug court, you have other options for rewards, right? You could reward a patient in drug court with less fines or less fees and reducing the burden that people have. You could, and they do this actually in Hawaii and in South Dakota. They have excellent driving under the influence programs where you can be contingency managed with a night in jail swiftly after you blow a positive breathalyzer. You don't get sentenced, you don't get convicted, you don't get a record, you get a night in jail. If you do it a second time, you get 3 nights in jail, like you lose a whole weekend in jail. So there are multiple rewards and punishments where the criminal justice system could actually use this approach very, very well. Another question is, I'd like to hear more about funding for community management, and I will talk about that shortly, so hold off for just a second on that one. Working with ACA members identified for substance use disorder, our reward program for reduced monthly premiums and copays are helpful. Yes, right, that's another approach where people have a monthly premium payment and they have copays, and you can reduce those, that's right. However, working with the Medicaid members previously, we offered rewards to spend for items they choose in stores. That seemed better. And that is absolutely right. That's what the research would predict. So reduction in fee obligations is a reward, but an opportunity to get things you care about is even more appealing. And there are other ways to enhance sort of the joyful, pleasurable, or fun aspects. And I'll show you an example of that one a little further. Okay. Let's move on now and keep sending in your questions into the Q&A box, and we'll get into the details of how to operate CM. Now, it's not just effective for MAT. CM is also effective for withdrawal management. That's important because many patients fail to complete their detoxes. And if you're doing a detox where you really have to complete detox to even start treatment, like with extended release naltrexone, it's really important to incentivize as many patients as possible to complete their withdrawal so that you can start the extended release naltrexone. So patients who complete withdrawal are at risk, first for relapsing, and they're at increased risk of opioid overdose because they've lost their tolerance if they're going through withdrawal. So it's really interesting to know that CM can reduce dropout from withdrawal. It can reduce opioid use during withdrawal, and that's a problem because it can prolong the withdrawal, right? And it can reduce opioid use after the completion of withdrawal. So it can really be a nice tool for helping people get onto their extended release naltrexone. And there are many other areas it's been proven to be effective for. Adolescents, family substance use treatment, non-opioid substance use treatment, alcohol, smoking, cocaine, even in the absence of MAT or methadone or buprenorphine. Patients with co-occurring psychiatric illness. Now, we know that psychiatric illness can exacerbate relapse and can even disrupt patients' cognitive functioning. But since CM is operating lower in the brain than the outer thinking brain, where cognition and learning are happening, it is still effective just like a medication would be effective, even if the patient has some cognitive impairments. So when we use CM in patients with co-occurring psych illness, instead of 25% of controls producing negative drug tests, no drugs, it's more than double that. It's almost 60%, 59% with contingency management. So it's a very impressive treatment. It works in the homeless patient population, even though they have so many challenges for getting through the day without relapsing. Abstinence at 6 months in a homeless population is almost triple what it is in patients who are in conventional treatment. So instead of 15% with conventional treatment, this study got 41% abstinent, almost half, at 6 months. Criminal justice patients, very effective. You can improve from 19 days of abstinence in a month prior to the assessment to 27 days per month, even in a very hardened criminal population. Pregnant women, you can get up to 90% opioid negative samples, and that's very critical because every additional 10%, that's another 10% of babies that are being born abstinent. Smoking cessation in adolescents. This study found 0% of their adolescents with conventional approaches were able to stay abstinent at 1 month, and with contingency management, half of them did. So again, very substantial effect sizes. Now, there are limitations. So let's spend a few slides talking about the limitations. One is cost. One pretty prominent approach using prize money or prize gift certificates is costing about $100 per month per patient. So we have to think about where are we going to raise that kind of money. Another is the study duration. Many of the trials are only 3-month trials. They look great at the end of treatment. Here it is. This large black diamond shows the sum of all of these effect sizes, these large boxes, and it's clearly to the right of this 0 line. There's no touching of the 0 line, which means it's significant, and it's very consistent. None of these average scores are on the left side of the line. That's amazing. But that's at the end of treatment, which might be as short as 3 months. What about at follow-up? Well, at follow-up, and this might be 3 months of follow-up, now this black diamond, which was well away from that 0 line, is almost touching that 0 line. And that means the significance is starting to fade. If we look at studies that reported what's the results 6 months after the contingency management ended, it's no longer on the right side of that 0 line. It's overlapping the 0 line and leaning to the left. That means we're not seeing the effect, and it's not significant at the end of 6 months after treatment ended. So that regression of CM effects means that for many patients, 6 months may not be long enough, or that it's not enough to have a single set of reward targets and then you just stop them all of a sudden. There probably needs to be a fade-out process and gradually transitioning patients to other healthy behaviors that give the patient more autonomy and more responsibility. Here's another limitation. It's labor-intensive. You have to do drug testing, and you have to do it right. You have to do attendance tracking, and you have to do it precisely. You have to do tracking of the schedules of reinforcement because they change. A patient might get $1 the first negative urine they produce, and 3 days later they might get $1.50, and next week on Monday they might get $2, and then by the end of the week on Thursday or Friday they get another urine test and they might get $2.50. So it's changing over time, every time, for each patient, and all the patients have a different reinforcement schedule placed. Also distributing the prizes. So if you're distributing to, your caseload, maybe you have 20, 30, 50 patients, you've got to spend time tracking all these things, logging them into some kind of a record, either a book or electronically, doing the accounting of the money, and one study estimated that it would cost $100 in staff time per patient for a 12-week CM program. So if you've got 25 patients, that's $2,500 of extra staff time that's costing the treatment program. Another set of problems is cultural resistance. We are a field that is overcome with inertia, unlike any other field in healthcare. Elsewhere in healthcare, they're changing their treatments all the time. New treatments are coming out. They're trying them. They're deciding if they work or if they don't like them and modifying their protocols. We don't tend to do that much at all. And for 80 years, since Dr. Bob and Bill Wilson sat down to talk, we've been kind of doing much the same approach. Now, that approach is very useful. It's not to criticize that approach. But we don't have a cultural identity that's constantly trying new approaches. In fact, we get kind of worried about new approaches, sometimes legitimately so. And we have this resistance in our general culture of paying drug addicts for what they should do anyway. And we share some of those worries. And there's some myths. The myths are, one, that, well, the patients will just relapse when you take the rewards away. Well, that's not completely true, and there are ways to block that from happening. So, for instance, we know that CM patients do slightly better than controls immediately after treatment and for a short while. And 6 months later, they're not doing better, but they're not doing worse than controls. But we do need to address this myth with a development, progress in our CM models. And that is still in progress. I have a big study out of Philadelphia and Washington, D.C. It's a $13 million federally funded study. We're going to use CM in that study. We just started it actually this month. And we're going to transition them from one set of CM targets, which is doing their drug testing and checking it and seeing what their results are with their counselor. And we're going to transition them over time to reinforcing them for doing their CBT activities in between their counseling sessions so that we give them more responsibility. There's a worry that prize-based rewards would encourage gambling. And that's actually been tested in 62 cocaine users who gamble. And they were assigned to prize-based contingency management, and it was effective for their cocaine, and they actually gambled less after they underwent the CM treatment. So patients know the difference between gambling to throw away their money for big prizes versus using a contingency management prize system to stabilize their addiction. Number 3, patients will spend the money on drugs or alcohol. There was a very nice study out of my group at Treatment Research Institute in Philadelphia. David Festinger led that. And what Dr. Festinger found was with 222 cocaine-addicted patients, when they were randomized to cash contingency management, to a voucher of gift certificates, or to a control where they didn't get money, cash was just as effective as the vouchers, and it didn't increase the patient's rates of drug use or of cravings or of other high-risk behaviors. And there are other ways to protect against spending money on drugs and alcohol that I'll show you, technologies that can help and can satisfy people who worry about this kind of thing. And those can be family members, they can be criminal justice people. So having addressed some of the limitations and some of the myths, let's talk about best practices. When should CM be used? Now, that question came up already during the break, and I really appreciate somebody thinking that through. I want to answer it a little bit more precisely. It can be very effective, not just during treatment, but even during active use. What I mean by that is they have done studies recruiting people who are actively drinking and who don't want to go to treatment, but are willing to be in a study to see if they'll reduce their drinking. So they don't even want to be abstinent, and they don't want to be in a treatment program. And what they find is CM works, even with those people who aren't getting counseling. It will substantially, not just significantly, but substantially reduce their drinking behavior. CM can be very effective to reinforce abstinence and early recovery when it's most critical to allow the brain to heal from the chronic addiction and to start being receptive to the counseling that we want the patient to learn from. It can be very effective to sustain recovery through the first years of recovery process, the beginning phase when people are most unstable and at risk of relapsing. So that first year is when you really want to be thinking about CM. And just remember, there's a load of ambivalence happening during early recovery. The patient wants health, wants to stop getting into trouble, wants to stop being sick, yes. The patient wants to be able to get high, wants to be able to escape, wants to get numb and stop feeling pain, yes. That ambivalence is the challenge. And when we counseling people are talking to the patient only, we're really fighting this disease with one hand tied behind our back, and we're not working as effectively with that ambivalence as we could. So, other best practices with CM. Let's see, did I skip a slide? No, good. We mentioned that it's based on operant conditioning. So we know a lot about operant conditioning. By the way, operant conditioning was first discovered in animals. It's effective not just in human beings, not just in primates like chimpanzees, not just in mammals like dogs and cats. And by the way, dog training, if you've done dog obedience training, you've done operant conditioning. Your dog has undergone operant conditioning. Very effective. Can train some very complex behaviors. But it's even effective down to animals like birds, chickens, can respond very effectively. So the portion of the brain that responds to CM is below the big thinking cortex that only human beings have in such quantities. And that's why it doesn't conflict with learning and counseling, but rather it provides a stable platform on which to do our counseling and recovery learning. So CM breaks down the recovery process into goals, and we can talk about them as targets, the targets of CM. The targets have to be concrete. They have to be very specific. They have to be measurable, like a clean urine, a negative urine for no drugs. That's measurable. It has to be concrete. It could be attendance at AA meetings. It could be completing a cognitive behavioral therapy homework assignment and coming in with the 3 things, negative thoughts that you came up with each day in the ensuing 7 days after the last counseling session, and the 3 things in the last counseling session that you said you would do when you start to experience negative thoughts, and a checkoff box for each day that you used one of those 3 positive, effective behaviors. So that's all concrete. Then it has to be attainable. If you say to somebody who's just starting medication, you'll be rewarded this next week if you maintain 100% abstinence. Well, that might be too hard to attain for a patient who's had a very chaotic experience using drugs and who's homeless. So what could we do that's attainable? Well, we might say you'll get a reward for undergoing your drug testing in the first week and reviewing the results with your counselor. And that's actually what we're going to do in my big 800-patient study in Philadelphia and Washington, D.C. So we want to make it attainable so that the patient gets engaged and feels hope that I could do this, I could get that reward. It also has to be realizable. The patient has to be able to manage it and manage it on an ongoing basis. So we want to sidestep the hopelessness that many people with addictive disease experience, especially when they become withdrawn and their mood state and their sleep cycle is bad and their energy level is low, and remember the neurobiology of addiction, their dopamine reward system is burnt out. So they have trouble anticipating rewards because of their chronic addiction. That neurotransmitter of reward, dopamine, in the brain is being secreted at lower levels. And so if we give them easily attainable rewards, very predictable, realizable, and they're concrete, we can get that dopamine flow produced and flowing and have them experiencing rewards for healthy behaviors instead of just having to suck it up and struggle through feeling negative and crappy and hopeless. So we want to reward critical recovery behaviors early in treatment, sustain them, and we want to prioritize those critical behaviors by the intensity of rewards. So how intensive should rewards be? That's a question. So first let's talk about setting goals, and then we'll talk about setting rewards, okay? The rewards will be based on what the goals are, so let's do those first. First, the goals should be frequent, at least once a week, preferably a couple times a week or more. They have to be attainable, and they have to be objective, so attending therapy, attending support groups, completing drug screens, reviewing the drug screens, having a negative drug screen. So some of these are in the same category, but one could be attainable early in treatment, like completing the drug screen, reviewing it with the counselor, and the other, having a negative drug screen, could be attainable maybe after the first month or 6 weeks or 2 months of starting OBOT. Attending a therapy session might be the thing we reinforce the first month. Once we've had a chance to do motivational enhancement, we've done some 12-step facilitation therapy, so the patient has thought through what would they like about 12 steps, what would they object to, did they go before, what different meetings could they try, how could they manage their perspective if some people are lapsed in their religion and don't want to go to churches for meetings. How can we start with attending therapy and then progress to rewarding for attending support group meetings? And of course, we have to rig the system to prevent gaming. We want people to not be able to fake their drug tests, not be able to fake that they go to their meetings. So how can we do that? Not so easy on first glance. So that's some of the best practice issues about setting patient goals. What about setting rewards? Well, the rewards have to be immediate to be most effective because, remember, we're trying to convert their attention span from immediate gratification for drugs to immediate gratification for healthy behaviors. And that's been studied. Immediate rewards are twice as effective as delayed rewards. So if you have rewards that you only find out about the next time you go into your clinic, and that's going to be after the weekend, you're going to lose a lot of the power of that reward by causing the patient to have that delay. And the rewards have to be tangible. It can't just be, oh, good job, you know, we're really proud of you. You can have some message like that, but you have to have some messages that are tangible as well. And they have to be matched to patients' needs. Now, some patients, I've had patients who were on a trust fund. I had a patient who could go out and buy a $20,000 bracelet at Tiffany's, and her stepfather would pay that. How is that person going to respond to $1 for reviewing her urine? Not so well. But then you have patients who are on assistance, and $1 might be a fine starting point for such patients. So we have to be able to match tangible rewards to the individual patient's needs. It's also important that rewards be intermittent. So you don't necessarily have to give a dollar amount for every drug test. If you do frequent drug tests, you can actually have rewards intermittently for only some of the drug tests. Now, how could you set that up? Well, you could put a bunch of tickets or coupons in a punch bowl, like a fish bowl. And some of them say, great job, keep up the good work, and some of them say, you've won a Big Mac. And some of them say, you've won $50. Now, in a fishbowl of 100 pieces of paper, maybe 60 or 70 say, good job. maybe 20 or 30 say $5 or a Big Mac. Maybe one is $50. And you can even let the patients know that. But each time they have a negative drug screen, they can draw one ticket from the punch bowl, from the fishbowl. And that's an intermittent reward schedule. We also need valuable rewards. They have to have some value to them. Now, how valuable does it have to be? And think of the theory of games. Any of you who've played video games, you'll play for points, and you'll play harder and harder the more points you get. And if you fail to, whatever it is, shoot down the spaceship, and you go back to the beginning, the first level, you don't give up. You don't say, well, these points don't matter. They're not money anyway. What do I care about points? No. You play harder. You get more compulsive about wanting to be successful. That's operant conditioning. It's not about the money itself as a means of supporting your livelihood. The money is just a signal to take it seriously, to pay attention. So you don't have to give the kid with a trust fund rewards of $10,000 for every negative urine. You just have to have enough money for them to think the game is fun. So if you think about casinos, they've got nickel machines or quarter machines, they've got dollar machines, and they've got baccarat tables where people are placing, $1,000 bets. Well, the $1,000 bets don't mean much to the people playing at those tables because they're multi-millionaires. But for the person who's on Social Security, a 25-cent quarter is meaningful, but it's not their livelihood. They're not playing to sort of get their next grocery check. So low-value rewards are half as effective as high-value rewards, but overall rewards are not for people's income. They're really just to grab their attention. So the reward schedule should be escalating. As the more the patient works on their recovery, the longer they do it, the more the reward schedule should increase. And if they turn in a positive urine with drugs in it, that should reset the next urine screen to a lower reward. It could go back to what the patient started at. You could even distinguish, if you could manage this, between the patient who fails to turn in a drug screen, they might get back to $0 or $1, and the patient who turns in a drug screen, but it's negative, and of course they know it's positive. And they know it's going to have drugs in it because they know if they used, but at least they had the integrity to come in and manage the monitoring of their disease. And so you might want to reset them back not all the way to the beginning. So escalating, resetting, and intermittent rewards, that's the best schedule for rewards. Now, that is a lot to manage. It's complicated. It's very detailed. One has to be meticulous. The records have to be legible for others to manage too. And how do we do this in a way that's easy, given that there's so many different things you have to work on? So I'm going to give you an example of a way that this can be done, and that is using the patient's own smartphone. And this can be added to routine treatment at multiple levels of care. So in the withdrawal phase, they can be doing this on their smartphone, on their when they get to day treatment, and when they go out to outpatient care. The same app on the same patient's smartphone can be managing their whole contingency management program. And their current care models continue. There's no change. They could be in their counseling. They should be doing outside recovery activities. The only thing is you add the app and the CM on top of those things. Now, what can you do with an app? Well, it's pretty interesting what you can do, actually. The app can text the patient when they have their appointment for counseling, so that they have to look at the app and they have to click, yeah, I see it, or it'll keep reminding them. And this is something that is routinely done when you want to get your teeth cleaned at the hygienist's office. And why is it that we have technology appointment reminders for dentists, but not for a disease that kills people like addiction? It can do more. It can track attendance. A smartphone has GPS location detectors that can tell the precise location that the patient is at. You can actually have the patient indicate with their phone, passively, without doing anything, whether they showed up to their doctor's appointment that they're supposed to go to the vocational rehab office to get their first appointment, to the AA meetings. You can even detect if they stayed for the full length of time with the GPS location. You can automate drug testing, and believe it or not, with a smartphone app, we actually have patients doing their own testing, not in the clinic. And that's a remarkable thing. I'll show you what it looks like in a moment. We can track reinforcement schedules. The computer has no trouble tracking that precisely, penny to penny, day to day, dollar by dollar. The computer in the smartphone can actually disperse the prizes, and it can measure compliance and report patient performance and outcomes to the counselor on the counselor's computer. The computer can alert the counselor when the patient is missing visits, like to not just to other substance use providers, like to group, but it could be to 12-step meetings, or missing their primary care doctor's appointment, or missing their dental appointments, and so forth. So technology can do a remarkable range of things. You can combine computerized CM with CBT counseling. This has actually been done. This technology assessed 507 patients with substance use problems in 10 clinics across the country over 12 weeks. And the average cost of prizes was $92 a month per patient. It tested for many different drugs, and it delivered a computerized cognitive behavioral therapy called TESS. And it calculated the contingency management reward schedule. The group that got TESS had 28% less likelihood of dropping out. So TESS is Therapeutic Education System. That's the green line. And you can see that when we're comparing abstinence between the green line and the treatment as usual people, that's the yellow line, the TESS line, the computerized CBT and CM, has higher retention, abstinence, this is abstinence, higher abstinence at almost every step of the game. Now, this is for people who started out abstinent, okay? So 100% of these people were detoxed and they were off their drugs, they start, and even though everybody wants to be abstinent and has succeeded in being abstinent, the yellow line, the treatment as usual people getting counseling, are almost at every time point doing worse. And at 3 months, they're still doing worse after the treatment. So the treatment is having an effect beyond the end of the study. What about the people who came in non-abstinent? They were still using and they agreed to enter the study. Well, the brown line on the top is showing how much better they are achieving their abstinence over time compared to the people who were doing the counseling in treatment as usual but with no CM and no computerized CBT. So even 3 months and 6 months later, there is a difference between these two groups, and the group that's getting the computerized technology is doing better. So there are multiple ways this can be done. For instance, you can do drug testing with a breathalyzer, and the patient takes it home with them, carries it around, pocket-sized, and they can do a video selfie as they're doing their breathalyzer so that somebody can watch that they're doing it the right way for the right amount of time. They definitely are blowing, and the breathalyzer is detecting if it's a true negative or a positive test. The patient has alcohol on their breath. You can do it with drug testing, too, with saliva testing, and that is being done nowadays. Medication adherence. You can issue medication reminders so that patients who have disorganization in their life, poor cognition, they can be reminded in real time what they should be taking, the dose amounts, and you can do video selfie. They can actually hold their phone facing them, see their face in the screen, take their pill with their other hand, take the glass of water and swallow it, and then show their mouth, move their tongue up and down and right and left, and show that they have swallowed the pill, and that's performing a video selfie verification. You can even have the patient do pill counts with their remaining buprenorphine pills to see that they still have the 29 pills left, or the strips, after the first day, and they can do that with video selfie verification. So some really great additional ways to monitor the patient, help the patient self-monitor, and assure that treatment is going as best as possible the way we want. So here's an example of an existing technology that patients are currently using. This is a pocket-sized breathalyzer. The patient has been told it's time to do a breathalyzer. It was a true random. They could be told to do this any time of the day, evening, weekends, holidays, periods when they're at higher risk of drinking, like July 4th, Memorial Day, Labor Day, Christmas, New Year's. And we can do this with saliva test kits and with a smokalizer. All of these now exist. They're pocket-sized. The patient can take it with them when they leave home all day long, when they go to the office, when they go to the movies. For instance, we've had a patient who is a salesman who drives long distances. He literally gets an alert on his cell phone while he's driving 150 miles. He pulls over to the side of the highway or at the next off-ramp. In his car, he does his breathalyzer, and the program knows exactly how he's doing. Selfie videos and breathalyzers. Here's a study that did this. This is one of the approaches that has been done with a smartphone. Actually, this wasn't a smartphone. It was just a simple flip phone. It wasn't even a program. It was just monitoring the patient through their flip phone. So 30 high-frequency drinkers who were not diagnosed, were not in treatment programs, and they did a 28-day escalating voucher approach, a payment total of $219 per month on average for the rewards. The flip phone and the breathalyzer were in the patient's own hands. They did this from their home, from their job, and they would send back videos of them doing their breathalyzer test, and they could earn rewards. And the tests were requested any time of the day from 7 a.m. in the morning until 11 p.m. at night, from 1 to 3 times a day. Now, let me show you first what happened. In the patients who were being monitored, that's the control group, their drinking went from this level to only very slight decrease, not much at all. That's days of drinking per month. The patients who did the monitoring with the CM rewards, look at what happened to their drinking. It plummeted, okay? This is not just a significant reduction, it's a dramatic reduction. And if you look at their drinks per drinking day, there's almost no change in the people who did the monitoring, even though they're paying attention and watching it and showing to someone else how they're doing. But if they had the rewards, they cut their drinking substantially in terms of number of drinks per day when they did drink. And they're drinking many, many fewer days. So you have to combine both of these findings to get the full impact of how much less drinking is going on. And yet, did these people who didn't want to go to a treatment program and didn't want to stop drinking completely, did they dislike it? Were they concerned about being monitored and the privacy of this? No. 86% who used the testing and got the rewards said that they were satisfied, either moderately satisfied or very satisfied with it. And that's one of the interesting things we find. So when we do reminders for appointments, to go to clinic or meetings or primary care or to go to work, we do reminders to go to work. And it'll say how many points, or in this case, it's virtual coins, which they can then use in a fishbowl draw or a spinning wheel kind of a game. And it says what is the meeting, what's the frequency of the meeting, when is it, what's the address they need to go to. It even shows them a map. And when it gets there, it gives them the opportunity to check in, but the GPS will actually confirm that. And if they do check in and they stay for the duration, they get however many coins they were supposed to get. Now, this is really valuable. I can tell you of a program that had recovery coaches monitoring patients after treatment in the community, and families are paying a lot of money for the recovery coaching, and they had a patient who they felt was going to every AA meeting she was supposed to and really benefiting and really stabilizing. Appreciate the technology. Patient is geomapped. What do we learn? The counselor is notified the patient is leaving after 5 minutes from every meeting, is not staying for these meetings. Well, that's a shocker, and it allowed the coach to do an intervention with the patient and realize this patient was building up to drinking and drugging. This was the first step of not taking care of herself. So this is where technology can really help. How do we make it fun for the patients? Well, we can offer different types of rewards, direct dollar payments, vouchers, or we can do a gamification layer with streaks of success and electronic coins where they can click to choose rewards from a fishbowl or spin a wheel, which makes it really fun. And you can see the rewards are $1, $50, $8, and gift vouchers. And you can have as many coins as you're winning chances to spin. So this patient has won 10 coins that he saved up, and you can spin the wheel 10 times. So there are lots of ways to deliver this when you're using technology. Now, somebody asked a question about, what about the rewards? How do you fund this stuff? We don't have, budgets or reimbursement for rewards. Well, it may not work for everybody, that's true. But look at this example. 87% of patients of opioid-addicted children in a survey said that they would be willing to pay out of their own pockets $200 a week for an incentive-based program. Now, that's more than double what you really need. And this market research study found that people want to pay. We also had a study of a debit card that has been developed for recovery and found that families are putting on average $300+ per month on the card for their loved ones in early recovery to be using. So this is an example of crowdfunding. Families, significant others are putting money into the hands of patients. And it's not comfortable to do that. You're worrying that you're enabling the patient to use that money to buy drugs or drink, or you're policing the patient and getting enmeshed, and that can provoke a relapse. So there are ways to use technology, including debit cards, to fund the patient's reserve funds for incentives to be drawn and made available to the patient to spend. So where could you get the money from? Well, the patient's own wages, welfare payments, disability checks, significant other and families, payers and employers. Now you might say, oh yeah, I'm sure, Aetna wants to pay money for people to have rewards to have negative urines. Well, guess what? They do. Aetna has already contracted with one of these technologies that I work with to pilot providing matching funds up to $50 a month per patient if the family matches their own $50 per month. And why are they willing to do that with the premiums that normally would be their profit? Well, they're willing to do it because they think they're going to save money on the health care bill of the patient, and they probably are right. Employers are now becoming willing to fund this, and we have a national telehealth company that is funded by employers to set patients up with this system. So the family responds to a message. Help Julia on her path to recovery. She wants to raise $823 for a 6-month treatment program. And the family funds incentives, or the employer does, or the payer does, or they co-fund. The patient receives a smartphone app. They download it from the App Store. That's easy to do nowadays. Most people know how to do that. And they get shipped drug testing devices, breathalyzers, urine, or preferably saliva test cups or a smoke-alyzer device that hooks right to their phone. And they get random alerts or smart testing alerts when they're at higher risk. Maybe the patient hasn't been showing up on time to their appointments or meetings. That's a time to increase the frequency of drug testing. So it says, please perform a saliva test. The patient does the test, and the app verifies that it's a valid test, and then money is deposited onto the debit card. So that's how it works for abstinence. Very similar for attendance. The patient gets an appointment schedule. Maybe it's from the EHR. It's dumped right into the technology. The alerts come when it's time to prepare to go, maybe the same morning, maybe an hour before. The appointment is complete. GPS validated it. The patient gets a notice. You just earned 5 coins. And they spin the wheel. If they get the coins converted into dollars, that goes onto a debit card. And this is just an example of how this technology can work. It turns out patients really like the reminder alerts. We have been using this, and patients say, this is one of the most important things I've ever had to help me, because I screw up my appointments all the time. I'm not used to appointments. I didn't have that kind of life. I can't remember them. I can't get up in the morning. This is a big help to me. And it puts the burden of effort on the patient. There's almost nothing the clinic has to do except set up for patients to get the message to download the app. The drug testing is not done with urines because that's not truly random. It's not really witnessed. And another thing, it's not patient-centered. Patients have told us that they feel dirty even if they're handing in a urine that they know is going to be clean. It's invasive, intrusive, and it diminishes their self-respect. It's humiliating. So saliva testing is something that they can do, and it's true random or smart testing. It's fully witnessed, and at the same time, it's less intrusive. So patients tell us they really like and prefer that, and it's actually hard to game. We've been testing that too. The rewards, the amounts received and the amounts remaining in the reserve are clear. It's immediately available to the patient, which is one of the best practices in CM, and it's graphically displayed so the patient can see over time that they're doing better and better. And the card is set up for early recovery, so it blocks them from accessing cash at the ATM machine so they can go spend it on drugs. It blocks spending at bars and liquor stores and casinos. We can actually set a limit. Maybe the patient needs $20 a day for any kind of purchases, but we can block them so they can't spend $150 a day. And it's real time, and it's accurate data about the patient's needs. We can run analytics on their spending behavior and drug use behavior and use machine learning, artificial intelligence, to detect that they're at risk of relapse before they relapse, and then text the clinician that it's time for intervention. It's beneficial to treatment programs to catch relapses before they happen so they don't lose the patient, and they can increase retention and see a noticeable quality improvement. Families can monitor behavior with support instead of enabling or policing, and payers are very interested in reducing hospitalizations. So CM is one of the best evidence-based practices we have, and yet most of us aren't using it, but we can. There are challenges, but we can solve those challenges, especially with the help of technology, and that allows us to do more development of CM. So we can learn how to individualize CM even better, and over time as patients' needs changes, and how to transition patients from CM rewards to natural rewards. So I'll stop there, and I'm glad to look at your questions now. And let me tell you the questions that we've come up with. So in drug court, court costs are nearly never waived or reduced. Yes, but that's in a system that doesn't understand the benefit of rewards to improve engagement. So we're now starting to work with, for instance, the City of Boston Parole Board is meeting with us next week to discuss how we could improve their retention and decrease violations. And they do care about that, especially during the opioid epidemic. And a system like this can really be effective for a large population. Another question is, what about using CM in work release or work release in substance use treatment programs? I think that's a great idea. Work release is a wonderful thing, and you can release people to work all at once, completely, or in stages, in phases. And that's a really good way to graduate the rewards. You can also punish people by making them miss a day of work if they are not compliant with their program, as opposed to just waiting until they lose their job. So CM is very appropriate, and at Johns Hopkins Medical Center in Baltimore, they have been doing a sheltered workshop CM set of studies that have been very successful, even with pretty complex patients, homeless and methadone patients. Okay, here's a great comment. I'm completely on board with CM. How can I get others to buy into the concept? So the first thing is education, and this slide deck will be available, and you should feel free to share these slides with your colleagues and your clinical directors and CEOs, and then feel free to contact me if you're interested in anything that I've been working with. But being a change agent in a system that doesn't change is a challenge. So it takes repeated efforts, education, and also, as you saw me do, let's pose the right questions. Are we really satisfied with the outcomes we're getting? Do we even know the outcomes we're getting? Are we doing urines in a way that really tell us what's happening with the patient, or are we just, fulfilling an obligation? Do we have charts on patients that show whether their urines are going in a good direction or a bad direction or starting to become intermittent? How much do we really know about our patients' behavior? We know what they tell us if we have a chance to ask them in a comprehensive fashion. And one of the biggest issues I like to bring up is the economics. You saw that I started with some attention to that. The economics of patient care doesn't get addressed, and it's a huge issue. Economics is a big issue in other things, like divorce. The divorce rate is dramatically affected by family income. So we need to ask patients how they're managing money. We need to help patients learn to manage money. And CM is a wonderful way to add that dimension to our therapeutic approaches. So I'm going to stop there, and I thank you so much to about 150 people who joined this call. And I wish you a lot of luck in trying to incorporate this.
Dr. Gastfriend, thank you very much. And that does conclude all of the questions from the chat panel as well, or at least incorporates them in spirit. And Dr. Gastfriend, if you're ready, I'm going to take control back of the presentation and bring us to conclusion.
Thanks.
Okay, so again, Dr. Gastfriend, thank you very much for sharing your expertise with the group today. And I did want to remind all of our participants that when I end the webinar today, your browser is going to take you to an evaluation of the webinar today, and you're going to be directed to FADA's new website. If you want to receive continuing education credits or a statement of credit for this event, do please complete the evaluation. You will be prompted to register or log in to complete the evaluation. For CEs to be reported to CE Broker, for Florida licensed healthcare practitioners, please do provide us with an accurate Florida Department of Health license prefix and number the first time that you register with the site. After you register, you will be directed onward to the evaluation. And what you see on your screen is just a sample evaluation. The one you see will be correctly titled with this webinar event. After you complete and submit the evaluation, you'll immediately see further guidance to access your statement of credit within your new member profile. Finally, you will get a second opportunity to complete the evaluation. If it's not convenient for you to do right away, you're going to be receiving an email from the system in about 30 minutes, 15, 30 minutes, something like that. And what you see on screen right now, that's going to be the sender's name is there, FADA On Demand. So that's what you can look for in your inbox. Do please be aware that this evaluation will close on Thursday, March 15th. So if you're interested in doing that and getting a statement of credit, please do complete the evaluation by Thursday, March 15th. And then finally, of course, I would just like to say thank you for participating in today's webinar, and would also like to recognize and thank especially the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. So have a great rest of your day, and hold now for the evaluation. Thank you.